Our next speaker is Rachel Havrlant. Rachel has a background in medical science and health information management and joined the Chronic Care for Aboriginal People team at the Ministry of Health in the department back in 2008. The team then moved to the Agency for Clinical Innovation, where Rachel is now, continuing work on closing the gap for Aboriginal people in New South Wales. Rachel.
Thank you. Morning, everyone. Before I start, I just want to acknowledge that we're meeting on Aboriginal land today and pay my respects to the Badaragal people of the Eora Nation and pay my respects to both elders past and present. So thanks for the opportunity to come and chat to you guys today about 48-hour follow-up. Has anyone heard of 48-hour follow-up before? Oh, good, some of my ACI colleagues, that's good. Phew. But yeah, just presenting on behalf of my the Aboriginal Chronic Care team at ACI, which is Raylene Gordon, who's our manager, and my fellow project officers, Lachlan Wright and Eunice Simons. So back in 2007 and 2008, the first Aboriginal-specific redesign program was done at the ministry called the Walgan-Telly Project, and one of the recommendations, statewide recommendations from that project was the follow-up of patients post-discharge from an acute facility. So we formed a working party in late 2008 that consisted of Aboriginal health reps from Area Health Services back in the day, and we used that group to really define what this process was going to be, what were the minimum requirements, any KPIs attached. So really that working group really set the scene for follow-up as it is today. It's for Aboriginal people aged 15 years or older with a chronic disease. And so the 4 chronic diseases we look at our program are heart disease, chronic respiratory, chronic renal, and diabetes. So they're the chronic diseases in scope specifically for our program. The working party decided as a minimum, follow-up should be a phone call. So that's a follow-up within 2 working days. It started off as 48 hours, hence the name 40-hour follow-up, and we haven't really moved to within 2 working days follow-up. It's a bit clunky. So everyone calls it 40-hour follow-up, but we all acknowledge that it's moved to 2 working days. So yeah, as I said, the majority of LHDs use a phone call, although some do home visits as their first mode of follow-up, and some, depending on how that phone call goes, some do escalate to a home visit if there are concerns raised in that initial phone call. So we talk about patient survey in a minute, but from the results from the patient survey, we agreed that the bare minimum, I guess, would be to ask these 3 questions on the phone call. So, how are you going? How are things post-hospital? Have you gotten home okay? Especially for those guys that need to travel rural into the city. Have you got your scripts, or did you get some medications? And have you got your follow-up appointments either back to your GP, Aboriginal Medical Service, or any specialist appointments you have? So I'm not sure how well you can see these, but the working party decided we actually needed to go out and ask Aboriginal people what they thought about this process and what they wanted from it. So they agreed that it would be a good idea. They preferred a phone call and a home visit, acknowledging those resource barriers. And their responses helped us assist with those 3 questions that I brought up in the previous slide. Just some more results about were they provided with any information on discharge already? So most of them had a GP, or a letter back to the GP, I guess, or their discharge summary. I'm not too sure. I agree with Kate. I'm not sure. This is back in 2008. I'm not sure the majority of them got that anyway. But and who would be the most appropriate person to do that follow-up? And overwhelmingly, they asked for an Aboriginal health worker or an Aboriginal person to do that follow-up. And then education, medications, and transport were the big 3 issues regarding their health at that time. So what we're trying to achieve improving health outcomes, reducing avoidable readmissions, and improving communication and linkages with those primary and community care services. So eligibility criteria for the program is Aboriginal patients aged 15 years and older with a chronic disease to be followed up within 2 working days from hospital by any member of the agreed health provider team, which could be quite a big blanket. So I'll touch on the models a bit later, but it could be a person within the hospital that's doing the follow-up, it could be someone in community health, it could be a referral or access centre. So we agreed to leave it quite open to allow facilities to have the flexibility to choose who that person could be. So the scope, as I mentioned, we've got 4 chronic diseases in scope for our program, and there are a list of ICD-10 codes that reflect those 4 diseases. So we're hoping to pick up people that are admitted specifically for their chronic disease, or their chronic disease might be a comorbidity at the time. So if they've fallen over and fractured their knob, or if they've been in a car accident and they've still got their chronic disease, obviously, then they still need to be followed up under this process. It's currently only for acute hospital admissions. There are some facilities out there that would like to do it for ED attendances. We're just trying to focus on getting the acute setting right first before we move on. So the KPI that we formed as part of the working party was that 90% of people should be followed up within 2 working days. And so how we calculate this from the numerator is the number of Aboriginal people that were actually followed up, and that data comes through each month from LHDs through to our team about the people that they've been able to follow up. And the denominator is who we've been able to identify through HIE data that we receive from Demand Performance Evaluation Branch on a quarterly basis about who should have been followed up. So we get that data after it's been clinically coded, so we use those ICD-10 codes so we can see breakdown for each facility who should have been followed up across the state and broken down. So 90%, we're a little bit off 90%, but we're improving each year that we've had follow-up in place. So we started off with a really clunky Excel spreadsheet for the reporting. And we're happy to say that about 4 or 5 LHDs are using Chime to actually document the follow-up, and then using that to extract reports to send in to us. So that's been a really great milestone for our team. What we'd like LHDs to report on is the number of people they identified for follow-up, and then who they were able to follow up within 2 working days. Who they followed up outside of those 2 working days. We agreed that just because the 2 working days stopped, then there should be a period where you still keep trying to follow up these people. Still really important. So we still do have quite a high number of people that are followed up outside of those 2 working days. The number of people who are uncontactable, number of people who decline follow-up, and those numbers have been quite negligible actually. We were quite surprised at that. There are really maybe 4 or 5 people across the state each month that say they don't want to receive that phone call. The number of people who are transferred to a different hospital, the reason we want to know that is they're transferred to a different hospital, it's really the hospital's responsibility whether they're discharged back to home or a referral, an aged care facility that is responsible for doing that follow-up, not the transfer to another hospital. There's really no point in doing a follow-up phone call. And the number of people who are deceased because they still pick up that admission data. The CHOC project has incorporated 48-hour follow-up into its documentation, and they'll be able to pull reports out of that system too. So when that system gets rolled out, that'll be another way LHDs can improve on this fairly clunky manual process. Looking at a little bit of data, Since 2009, we've got, I think at last count, it's about 98 hospitals that are performing 48-hour follow-up from all LHDs, even Broken Hill and some of the Barona, some of the really rural and remote places. On average, LHDs across the state are following up about 200 people within 2 working days, an additional 100 people outside of that 2 working day period. So what we're looking percentage-wise for the KPI varies each month from about 30 to 50%, so we've still got a lot of work to do to get to that 90, but the numbers are increasing, which is really promising, as well as the number of hospitals that are getting on board. Readmissions decreased by 4% compared to those who didn't receive a 48-hour follow-up, and that was shown in our evaluation in 2011. So we were still in the ministry in 2010, and with the help of their evaluation team, we looked at what we'd achieved in follow-up from 2009 to about late 2010, and the report was available in 2011. So we sent out a patient survey to anyone who was identified for follow-up, regardless of whether they were followed up or not. We did staff interviews for the staff who were actually the ones making those phone calls and going out to do those home visits. So staff interviews and a survey. We looked at the data that was collected, or that was received from the LHDs, just to look at, I guess, the performance of follow-up, and also to look at readmissions. There was some data linkages, and there was a literature review as well. So up there are the key recommendations that came out of that evaluation. And what we're working towards, this education and health literacy that came out really as a really big issue, as well as medication and appointment compliance. So a big barrier to appointment compliance is transport. So we're looking at an enhanced version of follow-up probably late this year. It is late this year, really late this year. Maybe early to mid next year we'll start looking at an enhanced model of follow-up, because there is a current evaluation happening again. The University of Newcastle is undertaking this evaluation. They're going to look at implementation across the state to see how LHDs have implemented it, and what's working, what's not working so well, and how can we improve. We'll again look at performance and see if that KPI is still relevant, and if that target is still realistic. The impact on readmissions, and we'll do another lit review to see if anything new's come on the scene since our last evaluation in 2011. So how are LHDs doing 48-hour follow-up? It really is truly different in every LHD, and even within LHDs, how each facility does it can vary quite considerably. It was initially implemented without any additional resources. So we travelled around the state back in 2009 and tried to get around the table discharge planners, Aboriginal health team, any exec members that we could wrangle, and primary and community care partners, and get them around the table and show them some numbers around, well, this is what we're talking about in terms of follow-up. And I think the biggest number one hospital would have had to do in a month was about 40 patients a month. So it varied from 40 way down to 1 or 2 a month. So depending on where we were, we provided them with that data, and let them kind of define a way about who was going to do it, and how it was going to happen. So we've seen centralised models in terms of referral and access centres. Their RNs or health workers doing the phone call, they'll receive a discharge report to see who's left hospital, and then follow them up that way. We've got clinical models where CNCs or RNs are the ones making the phone calls. Aboriginal health workers or liaison officers are making phone calls in some places, but it's really important that they have a clinical support person if questions do come up about medications, that they know who they can go to, or pass the phone on to someone that can provide that answers to those questions. And we've definitely got links starting to get links with the Chronic Disease Management Program, because back in last year, 2012, recurrent funds were made available for LHDs to have a dedicated position for follow-up. So recruitment has been a struggle in some LHDs, but with this money we've seen LHDs think a little bit outside the box and employ people in Aboriginal medical services or in Medicare locals to do that follow-up. And we've definitely seen linkages with the Connecting Care teams out there in LHDs. So we're planning a forum in 2014 to bring all the key players together to share ideas. We'll look at the recommendations from the evaluation that's currently underway and look about ways of improving the process for 48-hour follow-up. That was it.